All right, guys, this is our final section of 1150 special patient populations. To this section, we're going to talk about patients with special challenges, kind of all the things that you may or may not see, maybe once or twice in your career, depending on what kind of service you work for and how busy it is. So we're going to dive right in. We're talking about kids that are born prematurely that might have like congenital heart diseases, patients with neurological diseases, like we said, congenital or acquired diseases, sensory deficits, and geriatric patients with chronic diseases. We're going to start with developmental disability. Usually, you'll have kids in your first due, or everyone will pretty much know where this child is, because typically what happens is they've ran this child enough, or the parents are smart enough to come down to the fire station and say, hey, look, we have a child that we will probably have to call at some point, or over and over and over again, because we're going to need help. And this is what they've got, this is what's going on, and pretty much everybody in that station and at the service that will potentially work at that station is made aware that this child does exist in their first due. Really also, truly, for the developmentally disability children, parents are usually not apt to call right away. Maybe at first they are, because they're dealing with it and they don't understand what they're dealing with, but as they educate themselves, and the only reason why I know this is because I'm a parent of a developmentally disabled child, and as I started educating myself and finding things out for myself, I relied less on doctors and was coming more at the doctors and people who are medical professionals saying, all right, this is what I've read, this is what I got, is this right? Okay, so can we do this, can we do that? So parents are going to be your big key there. They do talk about the reasons and causes. There's a bunch of those. Genetic is usually a good one. An injury, especially a traumatic brain injury, that could also be potentially there. Things can develop in utero from prenatal drug or alcohol use. So, but don't assume that that's the reason. There's a myriad of reasons why a person might be developmentally delayed. All right, we're going to start with autism. Autism is a huge, huge umbrella term that a lot of other terms fall under. What you have is, for autistic children, is you have like behavioral problems, and really it winds up being a way that they can't express themselves, or the behavioral problems come because they're just frustrated with the fact that they can't communicate to you what they're feeling, and they don't know how to express those feelings, and sometimes they turn into fits of rage. But really, autism is one of the things that you'll notice is that repetitive motor activities. I know my daughter has, she loves to just do repetitive motions over and over and over again. And there's a lot of verbal and nonverbal impairment there. And really what that means is that they will probably mentally be locked in at some age. My daughter is what's known as severely developmentally delayed, and she is. They classify her with the mind of a 1-year-old to 18-month-old, and that's about right. I mean, she functions at that capability. She doesn't talk. But she makes eye contact, which sometimes usually with autism the eye contact's not made. There's no expression of love, but let me just tell you that that's not true, because I know even with my daughter, she doesn't hug me, she doesn't kiss me, but you can definitely tell that there's excitement and a bond between us. So don't take that for granted. The only reason why I can say that is just based on my experiences with my daughter. So the first one we're going to talk about is Down syndrome, and how Down syndrome occurs is the 21st chromosomes fail to separate. They wind up with a third chromosome. And I don't know genetically how that happens, but in those, as I believe is our DNA, we have a total of 46 sets. On the 21st set, it fails to separate. Somehow we wind up with a third extra chromosome on that set, and that's what causes Down syndrome. So this is definitely a genetic defect. And there's the picture of it. The physical abnormalities. Let's see. I've got this picture. So you got upward eye slants, kind of a nasal bulge, like a flattened, small, depressed nose, abnormal ear shape, small mouth, large tongue, crease across the palm, and some space between the toes. These are all just kind of things that are noted to be found physically with children and people of Down syndrome, just to let you know. Regardless of the patient's developmental ability and cognitive function and how they are able to think and process things, rule of thumb, and this goes with any patients, treat the patient how you want to be treated. Or, even better, treat the patient as if they were your loved ones, and how would you want your loved one treated? So, that's kind of the rule of thumb. If you do run these patients over and over again, someone may actually have a rapport with them. They may actually know them by name, and it may help to have that team member there to help calm things down if it works. Do your best to smooth things over, get a bond with that patient, get that patient to get your trust. It's going to be tough, so especially if you have developmentally delayed patients. Talk about brain injuries. This is typically caused by trauma somehow, some way. They say don't expect the patient to walk the stretcher. Of course, treat the patient with respect. Let me just tell you, that should be done on every patient. I don't care what the situation is. I know sometimes, though, you do have to kind of stick up for yourself if they're being disrespectful, but you got to try to maintain a higher level of respect than you're being given. So keep that in mind. So the blind, regardless of the cause, the best thing you can do with a blind patient is talk to this patient, regardless of what their complaint is. And they may have a myriad of complaints. It may not be have to do with anything with their visual prowess. So with a blind patient, once you recognize the fact that they might be potentially blind, introduce yourself, speak to them, let them know, hey, I'm going to touch you, and then give them a touch, and they work, and that seems to be more accepted, to actually touch them, like on the shoulder, on the arm, or on the hand. Say, hey, listen, I'm going to touch out, I'm going to reach out and grab your hand, okay? And they are okay with that, because remember, their world is dark, so they use other senses to be in their world. So, and what you can do for them is talk to them and talk them through things that are going on, because most of the things that you're going to be doing are not going to be in their everyday average daily life routine. Starting an IV, putting them on oxygen. Hey, listen, I'm gonna put this. This is gonna stick up in your nose. Gonna give you oxygen. It's gonna hook around your ears. Like, I know it seems silly to have to describe it, but you're going to be describing it for these people who are visually impaired, so that they have an idea of what's going on and what to expect. So, those are your tricks and tidbits for that. Hearing impaired. You want to be probably where the patient can see your mouth. Hopefully there's no visual impairment along with the hearing impairment. And you may have to speak louder, maybe a little bit slower, but don't talk to them like this. That's actually very insulting. There are a lot of, especially geriatric patients that have lost their hearing that are still cognitively with it. They still got a lot of brain function upstairs. They still know what's going on. So it's not so much that they can't think and they can't hear. They just lost their hearing. So go with that. So usually you're going to look for, talk about that. Oh, they do have signs for that. I know nothing about American Sign Language, so I'm not even going to try to tell you that I can teach you sign language, but apparently there's those. I would consult maybe with someone who does know American Sign Language. Hearing aids are going to be what kind of gives it away. They do make hearing aids now where they are not so obvious, because there are a lot of people are a little bit embarrassed that they have to wear hearing aids. I get it. It's kind of just a sign of getting old, and nobody really wants to get old, because the downside of getting old is dying. So nobody wants to hear that. You can help them with their hearing aids. Usually if people aren't wearing them and you show up and they want them, I usually just give them to them unless there's a reason why they physically can't put them in their ears. That way They know how to put them in. You're not trying to put them in for them. Don't clean them, and don't try to troubleshoot the problem. Don't be trying to change out a battery for them. If you have to, just kind of talk louder than usual and make sure that they can see your face and your mouth, because sometimes they can actually read lips. There are some different kinds. I'll let you look at those on your own. So now we're going to move into some neurological brain disorders. One is called cerebral palsy. And what this is, it has to do with some sort of traumatic brain injury. It could be a genetic cause, but basically what winds up doing is that they start losing lack of control and posture of their body. They start having the spastic limb movements, basically they're contracting, and they're actually kind of just shaking a little bit. They will have epilepsy. It says in here, I think somewhere, I think maybe on the next slide, it's 25% have epilepsy. I've actually seen more, but of course I don't run. I mean, the ones that I have ran, I've seen that they do have epilepsy, and typically that's why you're called out. Is they're having a seizure. Mom and dad have like rectal medications that they can give. They have like rectal diazepam or something of that nature, or some sort of rectal benzo that'll try to break the seizure, and it may not be working. So now they're calling you because like, hey, this is getting worse. So you may be called out there to do that. So again, do not assume that all patients with this issue or cerebral palsy have an intellectual disability. They don't, and don't expect these patients to be able to walk. They may have an unsteady gait or are prone to fall. Just because they have cerebral palsy does not mean that they have an intellectual ability. Basically, this is an issue of just having an ataxic gait, muscle control, movement, and being able to put that all together in their mind. Cystic fibrosis. This is a disease. Somehow it's a defect with the recessive gene. I really don't know much about it as far as its genetic cause. But what happens is that basically there's a continuous airway inflammation and mucus secretions that is continuous. It is continuous. So they are constantly having difficulty in breathing, shortness of breath. They wind up having to do a lot of breathing treatments. When they breathe, there's a good chance that they may actually get pneumonia constantly, so they might constantly be on antibiotics. So it is a genetic disease. It's kind of like having asthma 24/7. Like, it just does not go away. So they'll have to deal with that kind of stuff. So that's what cystic fibrosis is. Multiple sclerosis. Let me just get to the picture. All right, so multiple sclerosis has to do with the fact that there is a breakdown in what's called the myelinated sheath of a nerve axon. So what that means is that imagine, like, remember the nerve cell, you have the body of the cell, and then you have the axon that stretches out and goes to the other dendrites. And then it keeps going with the signal. And what it's kind of like having is, it's like, imagine you have wire, like that's a copper wire, and this is like an insulated sheath. And that way the message and the signal doesn't go spreading out. So what happens is there's a breakdown in the sheath, the myelinated sheath, obviously, for here. And now the signal is like escaping out in and around the tissue that surrounds this nerve cell, causing pain and uncontrollable movements and not being able to actually have good muscle control. So basically, in essence, for lack of a better term, and don't quote me on this, it's basically like losing the sheath and you're electrocuting whatever you're at, wherever the sheath's lost. So that's multiple sclerosis. That's how that works, also known as MS. Now there's MD, muscular dystrophy. It is different. This is also a genetic disease where the patients are born with muscle contractures and the muscle doesn't develop, and they slowly lose control over their muscles. They eventually lose control over their respiratory drive and die. That is how they die. It's very, very sad, very, very scary. There's a picture of that. Spina bifida, we've already kind of talked about, is where there's a loss of, in utero, there's a loss of the vertebral body, or the vertebral body does not grow completely, and the spinal cord or the meninges wind up growing out of the actual spine itself with or without cord involvement. So if you do deliver a baby, you need to be very careful. So we got to make sure that we don't damage that because there might be cord involvement with that. There's some of the pictures of it. I think I've had this up before. The vertebral body may not be there, but the cord's still intact along with the meninges. Hairy patch kind of gives that away, so be careful because now the baby does not have any support here. So if you see a very hairy back on a baby, might be cause for concern. We do have the it's called a meningeocele, where it's basically the meninges have grown outside but no involvement. And this is the myelomeningeocele, where you do have cord involvement. So that's spina bifida. Paralysis, the key words I want you to know here is hemiplegia. Paralysis of one side of the body. That's going to be like your stroke-like symptoms, where they have one side. Paraplegia is, or paraplegic, is paralysis of the lower, so the legs, from like the waist down. Quadriplegia is basically pretty much from the neck down. All four extremities have paralysis, and they cannot move that. We're going to get into some stuff with paralysis with trach tubes. I don't know why they didn't set this up behind it, but we will talk about trach tubes and with paralysis. The one thing, though, with people who are paralyzed, and even in older folks that don't get up and move more, you could have decubitus ulcers, also known as pressure ulcers. That's why it's a big deal in the nursing homes that the patients get rotated and moved like every 30 minutes to an hour, so they're not laying on their skin with the thinner skin and the bones pressing down on that thinner skin, causing it to have loss of blood flow to that area, where it actually starts rotting and decaying because it's not getting any blood flow. So that's a big deal. You might have some external devices that may actually have to help people through. That's called a halo, through the process of actually learning, putting their spine back together in an effort to hope that they do walk again. So that's going to be a pain. Imagine having to transport that patient on a stretcher. You'd have to really set it up and make sure they're okay. Also restrict spinal movements, stuff like that. So it is a good consideration that you've got to try to be very gentle, very careful, and figure out how to move that patient. Priapism, which is an actual erection caused by trauma because there's a loss of muscular tone or sympathetic tone to the genitalia area. That is usually a sign that there is a possible damage or spinal cord damage in males. So you want to really work on spinal restrictions. We'll talk about that more in trauma. Just kind of throw that out right now. Bariatric patients. So dealing with the bariatric, and if you don't know what that means, it's an obese patient. I really feel for bariatric patients. I really do. I know most people are pretty mad when they have a bariatric patient, and it's very sad because they feel as if some things should be helped, like it gets excessive to a point, and maybe rightly so, and I really can't disagree with that. But also, there's things that happen in people's lives that they don't understand psychologically, and it could be psychological, where they use food or something as a means of coping, and it could also be glandular. I mean, we can't just automatically assume that they are just having a psychological problem with food. So these patients are also special considerations. I know patients that I've transported true bariatric patients, and they are embarrassed. And they're very hesitant to call for help, but they do get to a point where they do need help at some point. And they feel very ashamed, and it's very sad because it gets to a point where it tips, and no pun intended, it tips the scale where they are no longer capable of physically trying to actually be able to work this weight off. So one of the things that you need to take into consideration is and sometimes we've been called out to just lift the patient up. The patient just physically can't lift themselves up. they are just too heavy and not strong enough to just pick themselves up off the floor. And you have to work very well with trying to figure out how to do it. Usually what I do is I take a sheet, kind of have fold it up in quarters long ways, so it's long, and then you kind of rotate them, have them, if they're here, you lean them over and try to scoot that sheet over, and then you have you get under their butt, and it's a nice pulling, hoisting mechanism. And then, believe me, it's a lot easier than trying to pick them up under their arms, which are weak. And what you do is you basically just hoist it up and over, and then you basically lift them to a standing position, let them grab something, hold on to them, and stand behind them so they don't fall backwards, that kind of thing. But they are very embarrassed regardless. So, and then another issue that you face is that you got to look at how much your stretcher is rated for. I know our new I think the Furnos are rated for 650 pounds. There are bariatric stretchers that will hold more, and they are wider than the normal stretcher. So if you need help lifting a bariatric patient, call for it. Get the other crews to come and help you. So, because you don't want to drop them, you don't want to hurt your back. I mean, it's a big deal. Again, treat them with dignity and respect. That's everyone. Anyways, and avoid trying to lift the patient by only one or two limbs. You can try to get your arm and hook it underneath their armpit and lift if they're not too bad. But like I said, I like to get something underneath their actual bottom and lift from there. You need routes that will accommodate the patient, and they'll be able to fit through those. So you need to look for that. You may have to scout that out before you actually try to leave the area, and before you try to get the stretcher in there and stuff like that. So look for a way to get out with that patient that will not hurt or harm or do minimal harm to the patient and you. I threw that picture in there because in the event that you hadn't seen a bariatric patient before, that's kind of like what you're dealing with, and it's difficult. It's very hard because how do you get this person who's probably never left the front door in months or weeks out the front door? And it has been where we've actually had to go out and cut door jambs with the chainsaw, make them wider so we could help the patient get out. And there's been times where you don't use a stretcher, you were able to help the patient physically get up into the back of the ambulance, and they sit on the floor with no stretcher. I mean, it's sad, and it's very, very, very pitiful, but that's, you got to do what you got to do. All right, so trach tubes. So you might have patients that have trach tubes, and usually these are going to be your quadriplegic patients. They usually have some sort of spinal issue above C4, because when we say C4, breathe no more, that's where the issue is at hand. Is basically at C4. That's kind of where the respiratory is innervated or comes out to be innervated into the lungs, and if that's damaged above C4, breathe no more, that's the issues you're gonna have. So that's the trach tube. It's basically it actually goes through the oh goodness, of course I'm gonna draw a blank, but it's in the throat itself, through I'm not gonna remember it. I'm drawing a blank, damn it. But this will be on the outside. You can actually ventilate from here. It'll hook up to a ventilator. This is inflated, and it's held in the trachea that way. Usually what you'll be called out for is difficulty in breathing or suctioning. You may have to go out there and suction, or there's something going wrong with the ventilator itself, and you may actually have to bag the patient through that. Again, obstructions. You can suction. I believe I know it's a paramedic skill. It may not be you that gets to do that, but usually people have caregivers or family members that are taking care of this patient, and they're doing all their care, like they're bathing, they're turning them to make sure that they don't get the decubus ulcers and things like that, and they usually are pretty good with the trachs and stuff like that. Mechanical ventilators, that's going to be the stuff, that's going to be what breathes for them. Make sure that when you're assessing the ventilator and the patient's breathing, make sure that when the ventilator is delivering a breath, you do have compliant chest rise and fall. If not, then the problem probably lies within the ventilator. They do make masks that go over a trach in the event that they do breathe on their own. And they just have a trach in place, and you can actually put like a mask over the trach and give high flow O2. I believe this looks like either a simple face mask or a non-rebreather that is going over the trach itself and then trying to introduce oxygen to it. Again, you can use a BVM and bag. I know in paramedic school that we were taught that if you lose a trach, we might be able to slide one back in. We can try. We might have to get medical direction to give us orders to do that. We can also use ET tubes in the event that we do lose that trach. Like I said, I'm not saying if it's in the scope of practice or not, but we usually have to ask for it. But that's the kind of things we can do if we get direction to go ahead and do it. Apnea monitors. These are for babies. This is to see if the baby is breathing, and it'll sound an alarm if they start getting bradycardic, because that's going to be the telltale sign that a kid is not breathing or oxygenating well, is they're going to drop into bradycardia. And so the monitors to let the parents know that they need to go and check on the baby, stimulate the baby, maybe even scare the baby with the monitor itself going off to scare the baby to wake them up and start breathing. And that's what they look like. It'll detect bradycardia. It measures the chest rise and fall, and if it's not moving, that's what will be an apnea monitor. Usually babies with some sort of inborn error of metabolism or something like that, or genetic issue, will have that if there are breathing problems associated with it. Pacemakers. This is going to probably be in your geriatric patients. You're going to see a lot of it. What happens is the pacemaker gets implanted, and the ends get put in somehow, some way, into the right atria and the right ventricle. And what happens is, and sometimes it might just be the ventricle itself. This is called AV sequential, and what will basically happen is the atrial and ventricle. It'll actually fire in the around the SA node, and then it'll fire for the ventricles, and it's actually doing the beating of the heart. Some people have demand, which means that it only comes on when their heart rate drops below a certain rate, or it might be continuous, which means their heart wouldn't beat without this. That means that if the pacemaker something was to happen to the pacemaker, they would no longer have a heartbeat. So if under the skin it looks like this, typically it's on the left side, left shoulder. So usually if you do a really good physical assessment, you'll find it really quickly. It should be very, very blatantly obvious that it's there. I think they last anywhere between 10 and 15 years, the battery life. So they also might have what's called an implanted defibrillator. It doesn't have to just be a pacemaker. It might be a pacemaker defibrillator. So in the event that they actually have some sort of VFib or any issue like that, it will like internally defibrillate them. So you may find that they may have a defibrillator. Sometimes these are over on the right side. Do not put if you're going to defibrillate somebody, don't put the pads over it. Slide it over somewhere out of the way, not on top of the pacemaker, and that way the electricity for if you decide that you're going to have to shock somebody will go through and it won't be blocked by the pacemaker. LVADs, left ventricular assist device. Let me just show you what it is. It's a lot easier to show you than explain it. Basically, these patients have some sort of heart problem. Usually they may have had a heart attack and they're no longer pumping blood adequately or sufficiently enough to perfuse the body. So they put an LVAD in, and what they do is they basically take the blood from the left ventricle. The heart still beats and moves. It still moves blood, but it's not enough. It's called ejection fraction. From the amount of blood that is pumped into the aorta may not be enough. So what happens is that LVAD is like a pump for the pump, basically. It'll take and it'll circumvent it around and dump it in the aorta. So it's helping it get in and around. So there's plenty of perfusion and movement of the blood. Usually you'll recognize these patients because they have a backpack kind of setup thing where there's batteries and control units and stuff like that. It looks kind of weird. and you're wondering what the hell, and it's actually something goes up in their shirt and in through their chest cavity to there to power this. So that's what an LVAD does. There is such thing as an external defibrillator vest. You don't have to have an internal pacemaker or an internal defibrillator. They can be separate or combined for internal. They actually have a vest. And what happens is the vest will pick up the fact if they go into VFib or have some sort of issue where they're in VFib, and it will shock the piss out of them. Sometimes the implanted or these vests wind up going off for no reason. That has happened before. I've actually had a patient that's being defibrillated, and he was not in VFib, and it's kind of scary. It's painful. Obviously, they're conscious, they're alert, and they're being shocked over and over and over again because somehow there's an error. So sometimes you can actually call their cardiologists and talk to them, and they can kind of walk you through some steps. Usually they do things over the phone, like through like modem like sounds and stuff like that. So it's kind of, the technology is pretty cool. But sometimes they're like, yeah, you got to bring him down here to me. I gotta figure out how to fix this. So it's kind of scary. Treat them obviously with like some pain management, stuff like that. These are intra aortic balloon pumps. All right, so this is also for the patient that has had some sort of heart failure. And what has happened is basically, I wish I could show you the graph of it, but this balloon pump senses when the heart beats, and it inflates at a seriously, and deflates at a seriously fast and alarming rate. So what happens is that this unit will sense when the ventricle pumps blood into the aorta, and when it feels that happening, it deflates really quickly. And then as soon as it stops beating, it inflates really quickly. And what it's doing is it's helping build pressure up. So it allows blood to pass through, and then it inflates really quickly, continuing to take this much of the section of the aorta and continuously, and then pump more of that blood through. So it's helping with the blood pressure and getting and perfusing blood in and around to the rest of the body. It's not really like an LVAD where it takes and just pumps blood over. With the LVAD, there's still some pumping action. Here, the pumping action is very weak or very nil. And so this acts as the pumping action for the actual ventricle. It's not, so I'm not really, like, most of these devices are kind of mystery to me as far as me knowing any more than what they do, but there they are. You do have central venous catheters. Basically, it's called a central line. Usually it's put in the subclavian, on either side of the vein. So usually it's subclavian. That you can have a central line in the brachial vein, stuff like that. So you can't use them. Congratulations. The reason why they probably have a central venous catheter is they're probably a horrible IV stick. And there you are, you needing to get them some medication or something, and you can't use their central line. So the good news is some medications can be delivered IM. So you might be able to go ahead and just give them a shot. But you cannot use it. Do not use, I'm telling you, from past experience, if you want to keep working in EMS, do not decide to use the central venous line. Even though you may know how to use it and how to do all these really cool things, you might be a nurse as well, just don't do it. I think we're getting towards the end here. We're getting down to the gastrostomy tubes. It's easier to show you than tell you about it. They're kind of four setups. One is the nasogastric. It goes here. The nasoduodenal, nasojejunal basically still goes to the nasal cavity, but to the duodenum or the jejunum. There's a J tube, which is the jejunostomy, goes into the jejunum, and then there's the gastrostomy tube that just goes right into the stomach. And what they look like is like that. Usually means that people have some sort of issue with difficulty swallowing, a risk for aspiration. They may have like esophageal cancer. There's a reason why they can't get food and nutrients from their mouth to their stomach. Or even past their stomach. They need to get past, there might be an actual issue with their stomach as well. So that's what they look like. That's what it looks like on a kid. They can become dislodged. Do not try to stick it back in. That is not your job. Your job is to just take them and have them professionally put back in, and obviously probably relatively quickly. I am curious though. It's kind of funny why the kid has a stick in his mouth. The first thing I thought was he has a lollipop, but he may not. I mean, I don't know. He may just not be able to actually drink or eat food, but he can have sugar. I don't know. Could be just got a straw in his mouth. I don't know. All right, so now we're gonna talk about shunts. There are shunts that basically go from the brain into the peritoneal space. It will literally, it's burrowed and tunneled in from the brain, the cavity, or the brain cavity, all the way down to the peritoneal space. The reason why this is done, or they can go in the right atrium, and the reason why it's done is that basically they make too much of the cerebral spinal fluid, and so to do that, if they couldn't have it somewhere to go because they make excessive amounts of it too quickly, it needs somewhere to go. They didn't have increased cranial pressure, so increased ICP, and so it would be very detrimental to the patient. So they wind up putting in shunts. They can have blocked or infected shunts. Reason for infection is this is a foreign material that's in the body. It can become infected and be attacked by the immune system. It can be blocked too. They do block sometimes. So if they have those issues, oh, there you go. There's a picture of the actual shunts themselves. They basically go from the cavity and they tunnel into the peritoneal space, and the body absorbs it and gets rid of it, and it goes from into the atria there, and it is also absorbed by the body and disposed of. Bulging fontanelles, projectile vomiting, altered mental status, high-pitched cry, fever, nausea, difficulty walking like ataxia, blurred vision. You can actually see redness along the shunt track because it's kind of just buried up underneath the skin, depending on where it goes. So at some point, usually it's like in the neck. So vagus nerve stimulators. These are for people that have severe and chronic back pain. So what they do is they stimulate the vagus nerve, and it helps ease their back pain. It looks something like this. It actually looks like a pacemaker, but it's a vagus nerve stimulator, and it'll actually hook in, and they wind up using like small electrical impulses to stimulate it to keep it from delivering pain. It kind of blocks the pain by kind of intercepting the signal and giving a mixed signal so that the pain is not felt and received by the brain. You've got colostomy bags, ileostomy, and urostomy bags that basically have to do with catching fecal material or urine, and where it does not come out the normal way. Let's see if I got a picture. That's what it really looks like. But in the event that they come dislodged, you'll see this little red poochy thing like that. That's where it is, and these are just different areas of where they'll attach. Don't try to reattach it. You can probably put a new bag over for the patient because the patients will change their bags. I will tell you that that somehow, some way, for fecal material that comes out of a gastrostomy bag is horribly stinky. And I don't mean to be rude, but it is very potent, very, very potent. So be polite, be kind. People are very embarrassed with these. Home care. Usually you have in-home health care and hospice care. They are different. Terminally ill patients usually use the hospice care. Obviously, they're sent home to allow them to pass in peace at home out of a hospital setting, surrounded by family members, and death is expected. We've already kind of talked about that with the geriatric patient and that the issues that might be there with that. In-home healthcare is different. Obviously, they're not expecting the patient to die. They're just having someone come out and check on them 2 to 5 days a week, depending on how it's set up. Make sure they take their medicines, maybe just cook them a meal right quick to make sure that they've ate for the day. There are people that do private sitting, and that means that they're just lay people on the street, or they used to be CNAs, or they still are CNAs or LPNs or RNs, and they wind up actually just helping out, and they're paid privately by people X amount of dollars. So even though they are nurses, and you get out there, you're like, I'm a nurse, like, okay, but I understand that you are and you hold a license. That's great, but you're not actually working in the capacity of a nurse. You just have the education. So you might run into some issues there. Facilities, private hospice, they do patient wishes. They do the DNR. They got to obviously follow local protocols and laws. Those are kind of a big deal. Go figure. And just keep in mind that if they do want the patient transported and they're on hospice, if it's the medical power of attorney, just know that hospice doesn't really like that, and sometimes they get mad and they'll say, okay, well, you transport the patient, you obviously don't want our care, and they may cancel the contract with that patient. So it's a big deal. It's a big I hate getting involved with hospice stuff, especially when they want them transported. The best thing to do if you can is like, hey, well, who's the nurse? Let's call the nurse. Let's talk to the nurse. Because usually the patient's medical power of attorney or family just like, oh, they're difficult breathing. Just, I don't care about hospice anymore. Just transport them. Just get them to the hospital. Save them. And it's kind of, in a way, I guess it's kind of selfish because the patient is terminally ill and there's nothing left to be done for the patient. And the best thing to do is just make the patient comfortable and let them pass naturally. And that's my opinion. I will throw that out there. That is my opinion. But I can also see the flip side where you're wanting to hold on to that family member, and it's very difficult to accept the fact that they are passing. So I get it, but still, anyways, you will deal with poverty and homeless people. I know, and when I did my clinical rides in Grady, we actually transported several homeless people. It was actually kind of weird. Like they pretty much understand that this bill will never be paid. But they still treated these people with dignity and respect. They did what they could for them. They would transport them, take them to the hospital. The hospital would take them, see them. I mean, you got to hand it to them. That's pretty nice knowing that you're going to get medical care, even though you're still respected and treated decently and receive medical care, even though you're probably never going to pay for it. You have no insurance. And that is it. All right, guys. I'll talk to you on the flip side.